All right, here we go. It is the summer of 2022. It's week 3. It's Tuesday. It's cardiovascular and pulmonary pathology day. And here we go. Today, the star of the show is thrombosis and its sequelae, embolisms, emboli. And we'll talk about some conditions, genetic conditions, and an acquired condition that increases the risk for this problem. Robbins says thrombosis is one of the scourges of modern man because it underlies the most serious and common forms of cardiovascular disease. It is a menace. It's the cause of many, many deaths because of its ability to clot or cause thrombosis. It's not the thrombosis. Well, that can be troublesome if that's in the brain arteries. Right, there's a thrombus right there, and here's the lumen of a blood vessel, and you can see it's a big beaver dam, and the flow of blood downstream is decreased. But a chunk of this could break loose and cause an embolism, and that's what's going to be could be catastrophic and deadly. Again, thrombosis occurs when blood abnormally sticks together, or coagulates together, or clots together, or thromboses together on the luminal surface of the endothelium or of the endocardium. So it's inside of blood vessels that this occurs. Histologically speaking, we said we shouldn't call this a blood clot because it differs histologically speaking than a blood clot. A blood clot happens outside of your blood vessels or in the tunics, in the tunica media. The blood clot really doesn't happen inside the vessel wall. Thrombus does. And there's some histological differences. It contains platelets, fibrins, and other entrapped cellular elements, which differs from that of a clot. We won't need to get that deep into that, though. And yeah, the thrombosis can cause a beaver dam. It can happen in an artery or a vein. Usually it's discouraged in arteries, though, because the blood is moving much more rapidly, and therefore it discourages clotting. But here's a thrombus right here, where platelets have gotten caught in a spider web of fibrin, and we'll look at that process a little more. So who cares about the beaver dam? Well, we've said already the thrombus beaver dam is going to cause downstream ischemia. We just said that. And it's dangerous because a piece can break loose. Here's the thrombus is up here where we can't see, but the piece of the thrombus is broken loose. And now it's like a bomb heading downstream. And remember, arteries or veins, they get smaller and smaller and smaller eventually, and it's going to get stuck somewhere and completely beaver dam a vessel. And therefore, anything downstream from the place where it's completely stuck, the tissue will die from that. Yep, everything I just said. That death of tissue is called an infarct when the death is from lack of blood flow. There are 3 big conditions that we'll talk about today and tomorrow that cause thrombosis. One is the classic factor V Leiden mutation. Should add mutation because there's also a factor V insufficiency. So factor V Leiden insufficiency. But this is factor V Leiden mutation. APAS, Antiphospholipid Antibody syndrome, we'll talk about both of those today. Cancer we'll talk about next time, but cancer can make the blood very clotty. It likes to clot when you have cancer. But let's look at some of these conditions. Let's remember the deep venous system. We've talked about this before. Actually, I think I have even another slide of this, but this is the danger because all of these deep vessels route into the inferior vena cava through the common iliac, through the external iliac, through the common femoral. These are all the deep femoral, the femoral vein. Remember, we don't ever call this a superficial femoral vein. We're trying to firmly get rid of that because physicians will see a report and it says superficial, or it'll say thrombosis of the superficial femoral vein, and they'll think, oh, I remember from medical school, chiropractic school, that superficial problem, superficial venous system clot or thrombosis is not that dangerous, which is true. But femoral vein is which used to be called the superficial femoral vein. That's a member of the deep system. It's a very dangerous place to get blood clots. So watch the terminology. Popliteals, we have the posterior, peroneal, and anterior tibial. Posterior tibial, anterior tibial, and peroneal veins. Those are all members of the deep system. Remember, this, I'm just going to call them clots because it rolls off the tongue easier, but this thrombosis process, or these clots, start in the calf usually, and they can cast and get and grow and grow and grow, and they can get very long, and they can break loose and go up and go through the heart and get stuck in the lungs usually. But yeah, those are the members of the deep system. Let's do some more definitions. What about a venous thrombosis? Well, venous means vein. Thrombosis means basically the blood sticking together or clotting together. So it's the process of a thrombosis formation within a vein. It's typically understood it's within the deep veins of the lower extremity unless they say otherwise. Arterial thrombosis is clotting in an artery, in the lumen of an artery. Deep vein thrombosis is more specific. That tells us the thrombosis process occurred in one of those deep veins of the lower extremities, one of these, probably down here in the calf or in the leg. Okay, DVT. These can be very dangerous. They can get stuck in the heart. They could get stuck in the lungs, cause all kinds of trouble. Superficial venous thrombosis, not that dangerous, but this is a sticking together of blood. It's a thrombosis of blood in the superficial, in the saphenous system mainly. In embolism, we already said it's a piece of thrombus that is broken loose or detached from the main body. Here's a nice picture, maybe in the posterior tibial vein that has the valves here, and here's a chunk broke loose, and off it goes to the races. It's headed for the lungs. Okay, you can also use an adjective to describe where this has gotten stuck. If it gets stuck in the lungs, you could call that a pulmonary embolism. It gets stuck in the coronary vessels inside of the heart, the left anterior descending, or wherever. It's called a cardiac embolism. It gets stuck in one of the hepatic vessels. It's a hepatic embolism. It gets stuck in the adrenal gland. It's an adrenal embolism. See how that works? How about thromboembolism? Well, that just tells us it's an embolism that came from thrombus formation, because not all emboli come from blood clots or thrombus. You can have a fractured femur, and fatty bone marrow can get into the veins, and you can have a fatty embolism. So they don't all come from, most of them do, but they don't all come from thrombosis. So this tells us the embolism came from thrombus formation. It's assumed it's in the deep veins of the lower extremity. Arterial thromboembolism. So that's a piece of thrombus that was growing in the arteries, unusual situation because of the speed of the blood that moves through an artery. But that arterial thrombus broke loose and caused an embolism. Doesn't tell us where it got stuck, though. Could be in the brain. Could cause a stroke. Those are really dangerous. Venous thromboembolism, or a VTE, or venous embolism, that's a thrombus, broke loose, formed an embolism, and it came from a vein somewhere. Pulmonary thromboembolism, same thing. That means the embolism got stuck in the lungs. Lungs means pulmonary, and it was thrombus formation. Simple as that. Thrombophilia, more definitions. Philia is something that you like to do a lot. It's usually pathological. And thrombo means clotting, basically the process of forming thrombus. So this is a person who is likes to form thrombus. This is a lot of stars on this slide. I'm adding every quarter. This is a very important slide. These names: prothrombogenic disease. That's somebody with factor V Leiden mutation has prothrombogenic disease. Hypercoagulable state. These people like to clot. They like to form blood clots. Hypercoagulable state. The person with factor V Leiden mutation, which we'll look at in a little while, is also has a hypercoagulable state. See how that works? Coagulopathy. Sometimes they erroneously use coagulopathy for hypercoagulable state, but they shouldn't, because that just means a pathological ability for coagulation. But maybe maybe it's the ability to coagulate. Maybe they coagulate too much. Maybe they don't coagulate enough. So that's a very open-ended term. That could mean a thrombophiliac or a hemophiliac. Both of those people have a coagulopathy. So watch out for that word. Right? Everything I just said. Person has a blood condition, either a hemophiliac or thrombophiliac. Just explained that, so don't need to do that anymore. What about thrombophlebitis versus phlebothrombosis? These are ancient terms that they're trying to get rid of. I think most of the medical texts have gotten rid of them. Rubens and Robbins, which chiropractors still use for boards, they're still hanging around, so you got to know these. But let's talk about, now they just call these, both of these now, they just call deep vein thrombosis. But let's talk about what they mean. So thrombo, that means thrombosis, the process of making a blood clot. Phlebo, that means vein. Phleb means vein. Itis is inflammation, so that is the thrombus of a vein that's occurred on a vessel that was already inflamed. So these people had a pre-existing inflammation of their, let's pick on their popliteal vein, was inflamed for some condition. Maybe got infected. Maybe they have or maybe they have some vasculitis. So anything that inflames a vein and then a thrombus starts. It's usually the veins again. Okay, classic causes again: vasculitis, vessel trauma, infection. Now, atherosclerosis usually doesn't happen in veins. It's usually more in arteries, but I guess it's possible you could get a thrombophlebitis of an artery, but that's not likely, though. Berger's is usually an artery. APAS, antiphospholipid antibody syndrome, it's got to be on this list as well, because that is an autoimmune attack against the endothelial cells themselves. Right? Phlebothrombosis, so there's no itis in here, so there's no pre-existing inflammation. So this is an AKA for deep vein thrombosis, Robbins says. Both of these are AKAs in real world for deep vein thrombosis, but this one in particular, Robbins says this is an AKA for DVT, and it's a venous thrombus formation within a vessel that did not have pre-existing inflammation. And that's what, how do you know if someone had pre-existing inflammation or not? And that's why this is kind of silly. But anyway, an example would be factor V Leiden mutation. Those people clot blood because of a mutation on factor V. It can't bind APAS, or it can't bind, we'll look at that in a minute. But there's no inflammation involved in that. So factor V Leiden mutation, person with that disease who got a blood clot typically could have phlebothrombosis, but again, I wish I'd just get rid of those things so I don't have to teach that confusing stuff. A hematoma is a blood clot, and that occurs either outside of the blood vessel or inside the tunica media. We'll look at some conditions called dissecting aneurysms, which split the tunica media and blood gets in there, and it can form a hematoma in there. That would not be thrombosis. All right, let's look at factor V Leiden mutation now. It's a very high yield board stuff. It's a very common congenital problem that makes you a thrombophiliac. Claim to fame, it is the most common congenital cause of hypercoagulable state, not acquired. APAS, antiphospholipid antibody syndrome, is the most common acquired cause of hypercoagulable state and thrombosis. But factor V Leiden is the most common congenital, meaning you're born with this mutation, and it's the cause of a hypercoagulable state. It's seen in about 5% of the population, so I mean, it's still rare, but it's not like Marfan syndrome, 0.01% rare. It's there. It's out there. I've known students come through the program who have it. So these people who have factor V Leiden mutation, they are thrombophiliacs. They have a constant hypercoagulable state. They're blood clotters is a slang. They're said to have factor or V Leiden thrombophilia is another word to describe them. And yeah, it's the most common genetic risk factor for VTE. We said that already. Testing for factor V Leiden mutation is the most commonly ordered molecular genetic test. And the scenario is patient will be in the ER complaining of really bad pain in the calf or thigh, and they get an ultrasound and they have a blood clot. Immediately they'll run some basic tests, and one is looking for factor V Leiden mutation, which is often found. Okay, in order to understand the mechanism of factor V Leiden mutation, we have to remember a little hematology. We remember APC, activated protein C. It is a major inhibitor of the blood clotting cascade. It shuts off the process of thrombosis. It shuts off the process of coagulation. How does it do that? It binds to two big blood clotters, one of which we already talked about, factor V, activated factor V, and activated factor VIII. Major blood clotters, it shuts both of them off normally. It has a binding site, it binds to them and shuts them right down. So it stops the process of thrombosis, and it stops the process of just regular blood clotting or hemostasis by binding to and deactivating VA and or 5A and 8A. It shuts them both down, these active factors. You should know that too, by the way. Recall VA and 8A are homologs. They're both super important for converting prothrombin into thrombin. Thrombin is very important for converting fibrinogen into the spider web, the scaffolding that holds thrombosis or holds a blood clot, which is fibrin. That's the ultimate product of the blood clotting cascade, and we need to group that together. But so fibrin plus red blood cells, that's what a venous thrombosis is made of. You should know that. Fibrin plus red blood cells. An arterial thrombus is a little different. It's made mainly of fibrin and platelets. It should have fibrin in there as well. Fibrin and platelets. Platelets are the star, though. Okay, here's the blood clotting cascade, just to refresh your memory. So I'm not going to go crazy into that. My voice is starting to go out. Let me get some water here. So remember, there's an intrinsic and extrinsic pathway, which we won't get into, but both of them produce the same thing, prothrombin activator molecule. So this prothrombin activator floating around, if it runs into calcium, it can stimulate the conversion of prothrombin and morphs it into thrombin. And then thrombin, by mechanism we don't need to worry about it, thrombin acts like a catalyst almost. It can take fibrinogen and catalyze it or morph it into a fibrin molecule or monomer. Just one strand of fibrin is not going to be able to snag any red blood cells or platelets. We need a spider web of these things. So with factor 8 or factor 13 and more calcium, the fibrin monomers stick together into this spider web of fibrin. So fibrin polymers, a whole bunch of fibrin, a spider web made up of fibrin monomers. And then that will trap either red blood cells or platelets, depending on what part of the blood you're in. Here's a beautiful electron microscopic examination of a polymer of fibrin. You can, all this green stuff, all this spider web is that's what we've made, fibrin polymers. And you can see it's attracted and clogged up with red blood cells, and that's classic venous thrombosis. Now replace this with platelets and you have arterial thrombosis. At least that's my understanding of it. What is this darn mutation anyway? Well, it's a single point mutation in a gene that makes factor V. What's a point mutation? That's where one amino acid is switched up. So arginine, specifically arginine, is replaced by glutamic acid, aka glutamine. Okay, so that mutation causes a mutated factor V. Let's be more specific. So the mutation actually occurs in the binding site. It occurs in factor V, but factor V has a binding site for the shutter offer. The clotting cascade shutter offer is activated protein C. So it has a binding site. Let's do some drawing. Let's try my new tools out here and see if they are going to behave themselves today. So here, let's say this is factor V right here. Okay, and this is the binding site right here. This thing right here, that's the binding site for APC. You can actually make it in red. I feel like drawing this morning. That's the binding site. So, and that's normal. The APC will make APC. That stops, that deactivates factor V. That will go in here and bind and shut down factor V, so it doesn't work. But in a mutated factor V, let's draw it again. We'll make it a triangle. We have a mutated binding site. So that binding site won't fit. And here's APC. There's the blood clotting cascade shutter offer. Is that going to fit in there? Nope. So there's nothing to turn it off. So factor V is just going to keep doing its job over and over again. It's going to keep clotting, and that's the problem with this condition, right? So the mutated factor V clots blood. Everything works just fine, but it can't be turned off. Why? Because it can't bind the turner offer, which is APC, or activated protein C. See how that works? Oops, why don't we? There we go. Scared me there. All right. What's the risk for this thrombophilia? Well, they're always at risk, right? You can't turn off factor V. And you can't turn off factor VIII. It turns off both of those. So you're always at risk for venous thrombosis and venous thromboemboli. And those people always are in a hypercoagulable state. They're thrombophiliacs, people who have this mutation. We can get more specific. People who have one mutated gene, remember we have 2 pairs of chromosomes in every single cell in all the endothelial cells, so maybe there's a 50-50 chance that the mutation will be transcribed and created. So people have an 8-time risk for VTE, venous thromboembolism. And not just venous thrombosis, embolism. That means it's broken loose. And that's significant. I mean, a twofold increase or threefold. This is a factor 8 increase. If you are unlucky enough to have both of your parents have the mutation and both of your genes are mutated, so you're homozygous, you should know the difference between heterozygous and homozygous too. Homozygous means both genes are mutated. Heterozygous means just one is mutated. You're 100, look at that, a factor of 100. You're 100 times more likely to have the mutation or to develop an embolism, not just thrombosis, an embolism. So that's significant. So we've been talking about the venous thromboemboli. What about arterial thrombosis? So we know that factor V Leiden mutation greatly increases the chance for thrombosis, for getting a blood clot. The research is a little mixed with regard to an arterial blood clot. Some has showed it does, some has showed it doesn't, so we're a little on the fence about that. But currently, there seems the chance of VTE is much greater when compared to arterial thromboemboli. So at least that's good. And that's not true of the next one we're going to talk about, antiphospholipid antibody syndrome. Right? So let's talk about the new champ here. And when I made this this lecture series probably 5 years ago or so, this wasn't, if you Googled antiphospholipid antibody syndrome, it really wasn't out there like Cleveland Clinic, Mayo Clinic. It wasn't on the internet very much. But now it's everywhere. So everybody's picked up on this because, I mean, it's out there. And this is not, you don't have to have a mutation for this. You can acquire this one. So it's the number one cause of acquired thrombophilia. So you're not born with this one. And it's the number one risk factor now for the development of deep vein thrombosis and pulmonary embolism. Now, factor V Leiden is a very close second. They're only about 5% apart. So some books say they're equal. Some books say APAS is the new champ. And so I'm going with the new champ here because it's more deadly, and it affects the arteries and the veins equally, where factor V Leiden mutation really affects the venous system more than the arterial system. Fun facts about it, women are much higher risk than men to develop this for whatever reason, about 5 times more likely than men. People who do get it are at much higher risk for developing SLE, systemic lupus erythematosus, sometimes just called lupus. And it's a problem more of young people. It typically shows up by about the age of 35 in the 4th decade of life. What is it? What is APAS? It's an autoimmune attack against endothelial cells that line the blood vessels. More specifically, it's against the phospholipids of the cell membrane of the endothelial cells. That's what gets hit by this. Even more specifically, the body makes autoantibodies against phospholipids. If you really want to get specific, it's an anti-beta 2 GPI IgG antibody, or you could call it an autoantibody, is the one that is out there. So, that should be percent. So yeah, we can test for that. The diagnosis is made by testing for these autoantibodies, these phospholipid autoantibodies. Trouble is, only about 40% of the patients will show this is true. So everybody put a percent sign right there, about 40%. So there's something obviously more to it. Remember phospholipids? So here's an endothelial cell. Here's the blood would be flowing right here. And this is a magnification of the cell wall of one endothelial cell. Remember, it's a phospholipid bilayer. And this is what gets attacked. So you get an autoimmune inflammation. Here's a real phospholipid. Remember, it's a choline phosphate, and it's got 2 fatty acid legs here. That's the phospholipid that gets attacked and causes an inflammation. It's found to be the cause in about 25% of people struck down by a thromboembolism. Another 20 to 25% is a factor V Leiden mutation will be responsible. Another fun fact, it's found to be the cause of stroke in 33% of people under 50. Let me say that again. A third of people who have a stroke under the age of 50, the stroke is caused by a blood clot. But what causes the blood clot? They have APAS. That's a huge, huge number. That's why this APAS condition is really catching on. Also, more fun facts. It's a major cause of recurrent miscarriages and pregnancy complications. when no other obvious reason is there. So they didn't used to figure out, somebody had a miscarriage, they don't know why, but nowadays they test for APAS, and a lot of people have it. And it has to be combated with anticoagulation medications, warfarin, Xarelto, things like that. Some studies specifically have shown 20% of miscarriages are now secondary to this condition. That's a huge number. It's considered an acquired autoimmune disease, so it's not a congenital thing. It's acquired. We don't know what sparks it, though. We don't know why all of a sudden the body attacks endothelial cells throughout the body. Endothelial cells of blood vessels. Maybe cigarette smoking, some pollution. I've said this story a million times. Maybe some chemical in cigarette smoke has gotten into endothelial cells, and it's gotten into the DNA, and it's turned on silent regions of the DNA, which normally is dormant, and it's woke them up. And so now the new endothelial cells that are born with this new gene turned on, they have a little different phenotype. They have a different look to them. And now the body it's not sure if it recognizes who they are anymore. And that's going to spark an autoimmune attack in most cases. It's been shown to increase the chances of arterial and venous thromboembolism by up to 40% if you're found to have this condition. The autoimmune attack causes inflammation, of course, of the endothelial cells. And then what causes the actual clotting to occur? It's not the inflammation in itself, but we've talked about this way back at the beginning of the class. When endothelial cells become inflamed and irritated and upset, they do two things. They stop secreting the slippery 3, including prostacyclin. So TPA, thrombomodulant, are not secreted, and they keep the endothelial lining of blood vessels slippery so clotting doesn't occur. And to make matters worse, we said that von Willebrand factor and factor 8 are over-secreted. And that's exactly what happens. So we've really already covered this. This is a classic scenario here. So it's very easy for thrombosis to form. We should talk about the perfect storm called Virchow's triad. I always ask a question about Virchow's triad. So it's a classic triad of risk factors that if you have great chance of developing blood clots. So there's 3 legs of the stool that have to be attached to make the diagnosis of Virchow's triad. Number 1, vessel wall abnormality. It's really easy to tick this box. All you need to have is atherosclerosis, which many people have. If you have hypertension. If you have hypertension, you're going to have vessel wall abnormality. You're going to have atherosclerosis. Remember we didn't get to that yet, but the chicken and the egg, atherosclerosis narrows the lumen of blood vessels, which increases blood pressure. That's hypertension. Hypertension roughs up endothelial cells, so LDLs can sneak underneath the epithelial cells and spark an inflammation. That narrows the lumen further, so we get a chicken and an egg scenario here. Hypercholesterolemia, cigarette smoking, these are all, if you do these, you have one leg of the stool attached already. You have a vessel wall abnormality. If you have an infection or autoimmune disease, that's a no-brainer, but that doesn't happen very often. These happen all the time. So to attach the next leg of the 3-legged stool, we got one leg on. You have to have a hypercoagulable state. You have to have either antiphospholipid antibody syndrome or factor V Leiden mutation or cancer. Those are the 3 big ones that can stimulate the blood clotting process. That one's more tougher to get that leg on the stool. The 3rd leg is not as easy to put on. It's only the 2nd leg that's hard to put on, or the 2nd box is easy to tick. This 3rd one is harder to tick. This 3rd box is easy. So you need venous stasis. So if you have anything that slows down the flow of blood, like sitting on an airplane for more than 4 hours, that's going to slow down the blood flow through your legs, and you're going to be in a Virchow's triad while you're on the airplane at least. You can wear compression stockings to combat that. Heart failure. Anything that lowers the flow of blood, lowers the blood pressure, can tick that box. If you have non-laminar blood flow from atherosclerotic narrowing of the arteries, that can make blood flow more sluggish downstream from the blockage. The natural history, this is more deep pathology than clinical pathology, but what happens if our popliteal artery is clogged up and you get maybe you broke your ankle, you've been laying around, and now you've formed a blood clot? What happens to that blood clot? Well, oftentimes it can get worse. It can move up into the femoral veins, starts in the popliteal vein, moves up into the femoral veins, into the iliac veins. It can propagate. So that's called casting. That's a very dangerous casting. Or a piece of it can break loose. Maybe the entire cast can break loose. And that will bomb the lungs with all that thrombus formation. Get some water here. Okay. On the good side of the coin, there are natural anticoagulants that can break down the clot. So sometimes the clot is dissolved if it's not too big. The clot may kind of petrify, reorganize, and be stuck inside the vessel wall and just become part of the vessel wall. So that's possible. It could cannulize. Maybe it's completely clogged a blood vessel. It could develop a hole within it and allow new blood flow. It doesn't happen that often, but it's possible. Sometimes if a vein is completely occluded, you can grow new blood vessels around the occlusion. That happens all the time. And that's one of the problems with filters that we'll talk about, is you get this new blood vessel formation that can bypass the IVC filter. Okay, thromboemboli, embolism. So we kind of talked about them a little bit. It's like here's the thrombus, and a piece of thrombus is broke off, and it's going downstream. It's going to get stuck somewhere. There's a piece that broke off here. The most common type of embolism is a venous thromboembolism, which comes from the deep veins of the lower extremities, which we've already went through. There they are again. There's don't ever call that the superficial femoral vein. I left it in here just to drive that point home. You should know the deep system, because I could say the patient developed a blood clot in the common femoral vein, which is a word you probably don't know. I don't think they got that detailed in anatomy, but you should know the common femoral vein splits into a deep femoral vein and the regular femoral vein. Right? Common, when you hear the word common, it means it's going to split. So then it becomes the popliteal, and then that splits into posterior tibial, anterior tibial, and fibular vein. And you can have different conformations there. Make sure you know those. And then the embolism means that it's not traveling through the blood. It means it's got stuck somewhere. 90% of pulmonary emboli, pulmonary meaning it got stuck in the lung somewhere. 90% of them that come from the deep veins, so they're called pulmonary thromboemboli. We've talked about all that before. They don't always come from the deep veins, though. They could come from a venous plexus that is around the prostate, called the pre-prosthetic venous plexus. There's also pelvic venous plexus. In females have that. Females don't have a prostate, so they don't have a periprosthetic venous plexus. It could come from the dural venous sinuses that you studied back in Gross 2. Could come from the inferior superior vena cava, the jugular veins, subclavian veins. So I won't go into my rant about thoracic outlet syndrome, but it's rare to come from the upper extremities. Remember, the artery is the one that passes through the so-called thoracic outlet. Now, arterial thrombosis, if it breaks loose and you get an arterial embolism, that's going to go away from the heart. It's going to get stuck down in your wrist. Okay, what about the symptoms of pulmonary embolism? Well, if they're small, we're getting bombed all the time with emboli. They're so small, they just dissolve. You won't have any symptoms. If they're medium in size, you're going to have some shortness of breath and a little tachypnea for a bit. May or may not require hospitalization for that. If they're big, they're going to not only include these symptoms, dyspnea and tachypnea, you're going to have pain, a specific type of pain. I think we talked about it before. With pericarditis, you have the same pain. It's called a pleuritic pain. That's like someone stabs you with a knife every time you try to take a breath in. And that's, yeah. So pulmonary effusion, you can have that. Dyspnea, tachypnea, cyanosis. Hospitalization is required. Death is possible, probably over 30% chance, even with treatment. So very serious conditions. All right, that's enough for today. Here's the bird for the day. Don't miss this. I had someone miss this last quarter. I had no sympathy when they begged for the point. You probably know this in kindergarten. That is an owl. So that's a young great horned owl I saw in Ogre Ponds, Morgan Hill. Shot that last winter. It's the only time of all my birding I've done for about a year now. It's the only owl I've ever saw. There was two of them, two siblings hanging out together. But that's a great horned owl. It's not a red-tailed hawk, right? It's not a common yellow throat. You guys should be able to get that. All right, see you guys later.